everybody, and thank you for joining us at the Healthy Life Show. I'm your host, Dr. Dalal Al-Aradi, and I'm happy to be with you this evening. Unfortunately, we will be missing Dr. NOOR NEBARI, and we hope to see her next week. So you can contact us through the following resources that you will see on the screen right now. Welcome back. So next we will be airing a short report that will be about the Kuwait 8th Annual Obstetrics and Gynecology Conference that was hosted at Radisson Blu.
I'm an obstetrician in the UK, in Liverpool. I work in a very big maternity unit. We've been doing a lot of work on looking after women who become very unwell in pregnancy so that we can treat them quickly and so we can prevent them being admitted to intensive care units or avoid dying in pregnancy and childbirth. So that's what I've come here to talk about. And I think it's particularly important here as you're just about to build a new hospital, brand new maternity hospital, and it's how you can build the systems in that hospital to make sure that you are recognising the rare situations when women are becoming very unwell and are at serious risk of severe complications or dying. I think it's really to build safe systems in all aspects of the care, but certainly in terms of recognising and acting appropriately when women are showing the early signs of becoming serious.
Program in the University of Toronto in Canada. So I had several presentations at the meeting. One is about rhesus disease and the newer ways of diagnosing and managing incompatibility between parents where the blood groups are different and intrauterine transfusion. And then looking at some of the more innovative forms of treatment of a fetus while it's still in utero, particularly identical twins. Some problems with babies' lungs, some problems with diaphragmatic hernia, some hearts, and then finally I'll be talking about kidney problems in the baby.
I'm Professor of Obstetrics and Gynecology, Department of Obstetrics and Gynecology, Kuwait University. And my practice hospital is Maternity Hospital. In today's conference, I gave a 5-minute talk about quality assurance in obstetrics and gynecology in Kuwait. I did emphasize the fact that two indicators of the standard of care, maternal mortality rates and perinatal mortality rates in Kuwait, are the same as in industrialized countries.
Hope you enjoyed our report. I would like to introduce our first guest for tonight. That would be Dr. Salman Al-Sabah. He is a consultant, general bariatric and laparoscopic surgeon here at Amiri Hospital. Hello, Dr. Salman, and good to have you here in our show.
Thank you for having me.
So, Dr. Salman, you are organizing a conference which is happening this week. Can you tell us what your conference is about, and who are you inviting for the conference, and who are expecting to come to Kuwait?
Okay, so the conference will be December 12 to 14 this month. It's the first annual Gulf Obesity Surgery Conference. It will be hosting international faculty from different parts of the world, from North America, from Europe, from Asia, and we want to make this conference as the main event in the Gulf region, because, as you know, obesity became an epidemic in this part of the world. We always ranked high worldwide in terms of obesity, as well as the disease related to obesity, such as diabetes. So we think this is an important event in this part of the world, so we can focus on the treatment of obesity and the related diseases.
So who are your target audience for the conference? Who are you expecting to show up? Is it just us surgeons, or do you expect others to join?
Sure. So we expect to have a multidisciplinary physicians, by surgeons, physicians, diabetologists, nutritionists, dietitians, as well as anesthesia. So all kinds of disciplines that are involved with obesity.
What about the general public? They're also
I think this is
target, I think.
Yeah, it's true. So this is an important also point. So the conference will be over 3 days. The first day will be live surgery, where we can transmit live surgery from Amiri Hospital to Jumeirah Hotel. And the second and third days will be lectures. The third day we're going to focus for 2 hours for public. So we want them to be there to listen to the surgeons, to the dietitians, and discuss with them options, as well as so they can understand what we are doing in terms of surgeries, and they expect, as well as before surgery, what things they have to do, and after surgery as well.
So when is your conference?
So it will be between 12 to 14 of December 2013. As you can see on the screen, it will be in the Jumeirah Hotel, and it will start at 8 in the morning and end up at 5 p.m. every day.
And the registration have already started?
Yes.
So people can go ahead and register?
Until today we have 500 people who are registered until today, and you can see on the screen we have the website for it. So we'd like to welcome everybody to register, physicians, surgeons, all disciplinary members of who are dealing with obesity to be involved as well.
So from those 500 people who registered, are they all from Kuwait?
Fortunately, we have people also from outside Kuwait. So, as I mentioned earlier, the focus of the meeting is the Gulf region. So, the main bulk of the participants are from the Gulf region. However, we have also people from Europe, from the States, are registered already for the meeting.
Dr. Salman, this is not the first conference that you have actually organized.
Yeah.
So I think you already had a conference 2 years back, if I'm correct?
Yeah.
And it's also about obesity. So how different is this surgery from the one that you've hosted?
Yeah. So the first conference 2 years back, we focused on Kuwait in terms of percentage of obesity in Kuwait and what kind of treatment options and how we can help our population in Kuwait. This time, instead of having each country has its own meeting, we thought as a group of surgeons in the Gulf to establish one event that put us all together under one umbrella, so we can share our knowledge, experience, and this conference, the first one will be in Kuwait this year, and next will be inshallah in Dubai, and so it will rotate between 6 countries. So make sure that all the surgeons, physicians in these countries, as well as patients, benefit from such an event.
Excellent. Dr. Salman, I remember also from the last conference that you have involved a research unit and you have involved some students and you had some research that was posted. What about this year? Do you have any posted this year?
So sure. So we started in 2011 to start a research unit at Al Amiri Hospital. I'm lucky to work with surgeons, great surgeons, dietitians, students, residents in Amiri Hospital. So we established a unit for data collection and having research done to can see our outcomes and improve our outcomes. So in Amiri Hospital, as we do all kinds of bariatric obesity surgery procedures, so we monitor these procedures, so we know what's our outcome. So at the end of the day, we can improve and we can share our knowledge with all parts of the world. So many of our students and residents have been presenting their work from Amir Hospital to all kinds of conferences, different parts of the world, and we are very proud of that. So in this conference, we have a few presentations, a few research projects that will be discussed in this meeting. And as you can see, we in our studies, we not only focus on weight loss. Here's a 4-year study that we did in Amiri Hospital looking at weight loss for patients underwent sleeve gastrectomy, which is one of the procedures we do for obesity. You can see up to 4 years we have excellent weight loss with this procedure, as well as treatment of diabetes, which is, I think, in this part of the world, we rank always first in terms of the incidence and prevalence of diabetes. So we can see here that 50% of our patients with diabetes, they get resolved from it by doing such a procedure. So this kind of procedures we find is very beneficial to our society. And this kind of projects also been worked out with medical students. They've been involved. I mean, we were supporting them to do such campaigns and awareness campaigns all over the Kuwait. You can see from this picture slide here, the medical students, most of them are now residents. This was a year ago. They've been hardworking to educate the society here in Kuwait. They did a great job in doing that, and we're using their data now to also to look at how we can improve things in Kuwait.
Dr. Salman, did you publish any of those research outside Kuwait?
Yeah, so we have until today 4 publications with the hard work of the residents. We've been published in peer-reviewed journal, which is really high-impact journals, scientific journals, that really the international community really appreciate our work here in Kuwait, because we have, as we mentioned earlier, high incidence of obesity, high incidence of diabetes, and we showed really good results. And then we've been invited to many conferences to show our results, so other people can learn from us. So we are really proud of that.
And how can anybody, how can they approach you? If any student or any resident want to participate in a research, how can they approach you?
So most of the time, the students or residents, they come to us by word of mouth. However, with such meeting conferences, they will have time to share with us if they're interested in doing such a research. So this is the most important why we need such a conference is done here in Kuwait. So we can not only have students from Kuwait, no, we can get students from the Gulf region to share and come and join us in doing such great work to help our people here in the Gulf region. So this is an example of how medical students been outreaching even schools and educating them, because you know the obesity starts at younger age, and we have a problem with child obesity as well. So we're trying to focus on different parts in Kuwait regarding obesity. One of them is awareness for schools and as well as malls. So this kind of conference will put things together. So at the end of the day, we can produce our result, show where's the problems and how we can improve on that. Not only by doing surgeries, by also involving dietitian, health authorities, awareness campaigns. So I think such a meeting can put things together.
I totally agree, and we're also proud of the work that you are doing. It's really an excellent job. Dr. Salman, we've been speaking a lot about the bariatric surgeries and the conference and the research, but a lot of people are wondering what is bariatric surgery, what comprises it, and what types of surgeries do we offer?
So in terms of bariatric surgery, so bariatric means obesity surgery, to make it simple for the audience. There's bariatric surgery could be by doing surgeries or without surgery. So let me start with surgery. So we have different types of procedures. We have the sleeve gastrectomy, which is here, you can see in the middle of the screen, where we cut about 80% of the stomach. So that procedure is the most common procedure nowadays, been done in the past 5 years. We have gastric bypass, which is still the #1 procedure done in the States, United States. We have gastric band, and we have procedure that does not require scars or without scars. So we don't do any surgeries to the abdomen, like the gastric balloon, where we use it with endoscopy, and that helps to lose weight. We have a new procedure, interventions being now advocated, like pause, where we go with endoscopy and shrink the stomach so prevent it from expanding. So these are less invasive procedure, and this will be a good opportunity that when physicians and surgeons attend to the conference, see what the new innovations in bariatric surgery.
And are we offering those new techniques or new treatment? Because all we see everywhere around us is sleeve. We're rarely seeing the
correct. I think this is a very important question to raise. Regarding sleeve, why is sleeve? Sleeve is being done actually common in the region of the GCC. I can show you here a graph showing sleeve gastrectomy between 2007 to 2012. You can see the numbers from huge increase. So 18,000 procedure done in 2012. What does it mean? It means that the procedure is safe. It means that the success rate is high and fits our culture and society. That's why you can see these numbers. We used to do bypass in the past, bands, but the numbers were small. You can see it here. Why is sleeve gained popularity? Because the results and the safety. Now, other procedures, if we're going to implement new procedures in Kuwait or in the Gulf, we have to make sure we have data on it. So all these procedures are new. So the data is still, people are still collecting data to prove if they are good procedures. Now, there is some new procedures that we're going to advocate in the conference. And so, again, new procedures will be coming. We look forward for it. As surgeons, we like innovation, and basically, but we cannot implement it until we have the data, the good results. We make sure it's done. Or if we're going to implement something new in Kuwait, then we should be with restrictive protocol, IRB, from the ministry, from the university, that we make sure that it's under strict research protocol. Then we can get new procedures into Kuwait.
With all those procedures, Where did that fit in the new guidelines? There was a hiatus for 3 months in which new guidelines were set. So what happened in those 3 months and what came out of it?
Okay, so this is more towards political question, but anyhow, so I'm just showing you the number of bariatric procedures done in Kuwait. You can see the year of 2012, there was about 6,500 sleeve gastrectomy done, which is really big number. Now, the guidelines, we are at Amiri Hospital or in Kuwait in general, we follow the standard international guidelines, which is BMI, body mass index, of 40 or a BMI of 35 with obesity diseases like such as diabetes or hypertension. This is the international guidelines. Okay. Now, these guidelines are more reinforced, okay, recently. However, we've been following these guidelines since we started doing this procedure.
With all these surgeries that have been done, what are the complications that the patient should fear mostly, and when should a patient seek medical help?
Okay, so this is really a great question. However, it needs more time. So I recommend that each patient, before undergoing any bariatric procedure, to discuss his case with his surgeon, and the surgeon will explain to him every single complication that you expect. Now, these procedures are safe, okay, just to make it clear. However, there is risk. It comes with any surgical procedure. There's risk of anesthesia. The patient will be sleeping. But we are in 2013, so the anesthesia are really doing great in terms of less complications. Patients feel better than before after anesthesia. And wound infections or clots, that could happen as well, like with any procedure. However, complication related to, for example, sleeve gastrectomy, just on sleeve gastrectomy, could be range from bleeding or leak, but this is low in percentage, about 1 to 2%.
So it's pretty a safe procedure, we can say.
Yeah, if it's done in the right center with the right surgeon.
And patient compliance. I mean, we face a lot of problems in our outpatient departments.
Yeah.
Do you face that problem specifically with post-sleeve patients, and does that impact the results of the sleeve?
So patient compliance is a problem everywhere in the world. When I did my training and when I worked in Canada, same thing. So the issue here with bariatric surgery is unique. Why? Because it's a lifestyle change. When you do the procedure, the patient should understand it's a lifestyle change. So the eating habits will change. The way they live, it will be different because they have to exercise, they have to follow orders. Now the procedure, to make it simple, I always tell my patient, 50% is on me as a surgeon and the procedure, and 50% will be on the patient. It's not all kind of procedures are not a miracle. It's a method that helps people to lose weight. So if they don't follow up with us and they don't follow up with the surgeon, with the dietitian, with the multidisciplinary team, then most likely they will fail the procedure. Okay, so again, follow-up is an issue, but we try at least in our hospital to make sure that we follow them by phone calls, and we make sure that they come back to us, whether by the surgeon, by the dietitian. So it's an issue, but we're trying to overcome it. It's not only in Kuwait, it's everywhere in the world.
So a lot of specialties or specialty doctors and even patients are saying sleeve is a bubble. Do you think that sleeve is a bubble and that is going to burst someday?
I don't think so. So sleeve, now we have data for 10 years, and it's safe with excellent results. You can see the numbers here in Kuwait is increasing, number of procedures. So that gives you a sign it's safe and it's not a temporary procedure. Now we always look for innovations and better procedure, but until now we think sleeve and gastric bypass are the gold standard procedure that we can measure outcome according to these two procedures. So 10 years results, excellent outcome. It treats obesity and comorbidities like obesity-related diseases such as diabetes. We treat diabetes. We showed you earlier the result of Amiri Hospital for the treatment of diabetes with such a
Excellent
procedure.
results.
Yeah. So I think at this stage what we have, the best option is either a sleeve gastrectomy or a bypass. Depending on the patient situation, the surgeon could give a patient the best advice depending on the patient himself. And I'm saying patient because now the American Medical Association last year recognized obesity as a disease. So that's why I call it patient. When I used to work in other places, we call them clients. But now it's a disease, so we should have all kind of multidisciplinary teams to help us to treat such a disease.
So we were speaking a lot about outcome. If we have the perfect patient, how much weight should they expect to lose from bariatric surgeries, whether it's a sleeve, whether it's a bypass? How much are they expected to lose?
Okay, so to consider the procedure, whether sleeve or bypass, to be a successful procedure, they should lose 50% of their excess weight in 1 year. Okay, so this is one way of looking into success. The other way is a treatment of the disease associated with obesity, such as diabetes. If the patient came not only for obesity, for treatment of diabetes, obese patient with diabetes, then this is another success that we treat the comorbidities. I mean the diseases related to obesity. If that procedure treat that, and the patient lose more than 50% of his excess weight loss within 1 year, we call that a successful procedure.
So we have a question from one of our viewers. She's asking, she has a child less than 15 years of age. What about the recent guidelines regarding those special kinds of patients? Is surgery an option for them?
Okay, so these are special situations, patients under 16 years of age. So we can do this the child. However, we have to make sure that this patient or the child or the kid's been seen by full team of endocrinologist, surgeon, anesthesia, psychiatrist, to make sure it's safe for him. Now, it depends also as the BMI, because our guidelines here now in Kuwait, the BMI should be more than 50. Plus, the other members of the team agree on such a procedure. Because it's all about balance at the end of the day. If the obesity will affect the child more than doing the procedure, then we're gonna go with the procedure. So it's the decision based on multidisciplinary approach and as well as the BMI more than 50.
We have another question from another one of our viewers. She's saying that she had a sleeve done with her sister at the same time. She ended up with a drain, her sister didn't. Is there a difference, and why did she have the drain?
So drains means a tube we use that we, through the skin, we leave it to suction the blood or any content from the abdomen. So the idea behind it if the patient bleed, you can see it through the drain, so you can see blood through the drain, or the patient have leak or disruption of the healing of the stomach, then the content will go through the drain. However, there's many studies show that the question if it's useful or not. They question it because personally I don't use drains unless there is expecting the patient will have his tissue is very friable or he's more towards bleeding, then I will leave a drain. Otherwise, I think this is a surgeon preference at this moment, and there's no data suggest to use drains in all patients.
Another patient, also female, so many female patients, she's asking when can she get pregnant after sleep?
I think this is a great question. We always recommend after a year and a half from the procedure. And the idea behind that at this stage, after a year and a half, their weight will plateau. So it will be stabilized. And then when she gets pregnant, she can give enough nutrition for the baby. If she got pregnant before that, then she will not have enough nutrition, she cannot eat enough, so we don't recommend that. Let's say the patient, which happens, got pregnant in a less than a year, then with the help of the obstetrician, we recommend to increase their vitamin dose more than the usual pregnancy, and we make sure that they follow with us with the obstetrician for the time period of pregnancy.
This is a question from me.
Yeah.
We always advertise sleeve as a surgery that does not end up with nutrient deficiencies.
Yeah.
So why are we at the same time asking them to have supplements?
Okay, so this is a great question. Now, at the beginning, sleeve gastrectomy, we don't change any of the anatomy except of cutting part of the stomach. We know from our experience and from the studies that the patient needs supplements. They need B12, they need multi B1, B6 vitamins, which is important in sleeve gastrectomy. They need also some elements like copper or zinc. So we recommend that during the follow-up, that's why the follow-up is important, that we do blood test and check for vitamin deficiencies or trace element deficiencies, and then we treat them accordingly. However, my recommendation, and not only my colleague as well, that we keep them on multivitamin throughout their life.
We also have another question, if that's also a little bit political. She's asking, why is there a big difference in the price of the instruments? She's saying that some surgeons offer her a very low instrument price, and the others are saying it's high. Is there a difference in the instruments that you are using in sleeve gastrectomy?
So it depends. So there's two main companies worldwide that distribute instruments for such a procedure. Both companies are excellent, and their equipment work very well. Now, the price difference, it comes on the preference of the surgeon, what kind of equipment he uses, and the stomach again is different from one patient to another. The number of cartridges or the number of staplers that we use could be less or more depending on the patient. So that's why there will be a difference in price.
So we have another question. She's saying that she's 29 years old and she weighs 190. She went to the hospital and she was asked to lose 20 kilos and to have a balloon inserted. So
I think, this is depends on the surgeon preference. My own experience when I came here to Kuwait in 2011, for morbid obese, such as a patient with more than like 150 and more kilograms, I used to put for them a balloon, and then after that do procedure. But nowadays I stopped doing that for many reasons. The first reason is that the patient needs to be under general anesthesia. He needs to be sleeping for 3 procedures: for putting the balloon in, for removing the balloon, and for the sleep. So you're putting the patient for risk for 3 procedures with anesthesia. Number 2, which is more toward technical, the stomach, after we insert the balloon, it gets thicker. So the devices we are using to cut the stomach, it will be difficult to do such a procedure because the stomach is thick, and we get worried with that. So if the patient, let's say, had a balloon, we recommend at least 3 months after the balloon, you don't do surgery. However, I think it's safe 3 months later, once the balloon is out, you can do sleeve or bypass. But again, from my experience, I stopped doing that.
So just one last question from a viewer. What about the sleeve protection methods?
Sleeve protection.
I mean, for the devices, I think we're using protection on the devices. Do they make a difference?
Okay.
I think they mean very strips for that.
Okay, yeah, so protection devices, it's still under debate if you use it. There's many studies that show that using covering devices to make sure that to reduce bleeding and leak. However, for bleeding and leak, it's still debatable regarding using such a material. However, depends on the anatomy and thickness of the stomach during the procedure. So yes, some studies recommend using peristrip or any supportive material on the stapler, and they they have paper or scientific paper to support that, and others disagree on that. So in the meeting, we'll have a full session on the same topic, on leaks and how to prevent that. So I think this will be a good opportunity for surgeons and health professionals to be there and to listen to such high caliber speakers that we invited. We have 18 speakers who will be there discussing all these small techniques and all kind of bariatric procedures and how to prevent complications. So it will be a good opportunity that if they can join and look at this discussion.
And I hope you allow us, KTV, to be present at your conference.
You're more than welcome, and I'll take this opportunity to welcome everybody to the meeting, and we'll be happy to share our knowledge with you.
Dr. Salman, any last words? Do you have any advice you can give our viewers? If there's one advice that you would give them, what would that be?
So my advice is that first of all, we have to know that obesity is a problem in Kuwait and in the Gulf region. I think all levels of the government and foundations in Kuwait, as well as physicians, they should be involved in helping our patient with obesity because it's a disease. I think if patient is thinking of doing such bariatric or obesity surgery procedure, they should make sure that they understand what they are going through, who are their surgeons, and what if the center is capable of doing such a procedure, and to make sure that they have to know that it's a change of lifestyle, and they have to make sure that they follow with their surgeons and dietitians on a regular basis so they don't have any problems.
Thank you, Dr. Salman. It was really a pleasure having you with us
It's
today.
my pleasure. Thank you.
So next we'll be airing another report. We'll take a short break. The report is very dear to my heart. It's the 4th annual Kuwait Breast Diseases and Oncoplastic Reconstructive Surgery Conference. This was hosted at Mubarak Al-Kabir Hospital and with the Faculty of Medicine. This included lectures, video and live theater sessions that was aired also through Mubarak Hospital. So let's take a look at the report.
Saleh, Associate Professor, College of Medicine, Kuwait University, and Senior Consultant Surgeon, Oncology Surgeon, and General Surgery. Thank you very much for attending our conference. This is the 4th year, Annual Breast Diseases and Oncoplastic Reconstructive Surgery. Our aim of this conference is to establish standardization of breast care, educational of doctors, medical students, and doctors who deal with problems of the breast.
Dr. Musa Khurshid from Department of Surgery, Faculty of Medicine, Kuwait University. I'd like to just give an idea about this meeting, which is one of the best meetings that I have seen in Kuwait. It covers all aspects of breast cancer, and recent advances in oncoplastic surgery. This is something which has been developed so much over the past many years, and many young women in their 30s and 40s, they get breast cancer, and it's number one in Kuwait. And for that reason, sometimes we need to do surgery to excise the tumor. So there has been a lot of progress over the past many years now, 30 years or so. So we are going more and more conservative in the management of breast cancer, in the treatment of breast cancer. So we don't need to remove all the breast now. We don't need to remove all the lymph nodes unless we need to. And there are different options. And one of those options is the plastic surgery if we have a big tumor or big mass in the breast where we need to remove that mass. So the concept of this meeting is combining breast cancer surgery with reconstruction of the breast or rebuilding a new breast with the same shape, with the same image, and this is called oncoplastic surgery. And we are lucky to have many guest speakers this year with us in Kuwait, and I must congratulate the organizing committee for the wonderful work they have done. In particular, Dr. Merbet Saleh, who has done a great job in organizing this meeting for the past 4 years. This is a wonderful work that puts Kuwait on the map and tells many people in the world that, you know, this kind of surgery is being practiced here in Kuwait safely.
I'm Senior Vice President of Business Development at AHMED in Germany. What we have is a new technique for getting very gentle pet grafting for body-owned material, for example, for plastic surgery, reconstructive surgery. And what we have as a new technique is that we're doing it in a very gentle way with a water spray. No laser, no ultrasound or any other energy. And this causes that the patient does not need general anesthesia. And also, it is a very, very short recovery time. That is basically what we're introducing here with a device with a body jet.
Thank you for staying with us. Now we introduce our next guest, dietitian AHMED, also from Amiri Hospital with a master's in clinical diet and nutrition from the University of Florida in the United States, and a member of the ADA. Welcome, our dietitian.
Thank you. Pleasure.
Thank you for coming to our show.
Thank you. Pleasure.
Okay, so we will basically continue straight from where Dr. Salman left. We were talking about the conference, we were talking about bariatric surgeries, and we were talking about, and we mentioned about nutrition. And here is where you come in. What are the post-surgery guidelines that we are using in Kuwait, or are you using specifically? And are those guidelines local from our research and from our patients, or are they adapted from worldwide guidelines?
Okay. First, we started around 5 to 7 years ago with the bariatric surgery in Kuwait. When we first started, we didn't have any statistics, no studies, no anything. So what we did is that we took the American protocol and then we customized it to fit the Kuwaiti culture, the Kuwaiti food, the eating habits. So it's based on the American system, but it has a lot of stuff that we over the years have added based on the patients we see, statistics we have, problems we face.
So it's basically modified to some local sense.
for the Kuwaiti culture.
Are you also using those results based from research that you are doing, or is it mostly just patient-to-patient interaction?
Mostly patient-to-patient interactions. We don't have like a specific research for the diet part. Most of the research that is going on is based on the like diabetes, the medical status of the patient. We still didn't get into the problems, nutritional problems for the studies. But basically, it's like from the sessions we see from the patients. Sometimes people ask over the social media. That's how we gathered all the information to put together a protocol that suits the Kuwaiti culture.
Ms. Amna, when do you first meet your patient? Is it usually before the sleeve or after the sleeve?
If you're going to follow the protocol, it's supposed to be before and after. But in Kuwait, they come to the surgeon, they want the surgery. So they're not going to try any diet. They don't want to go over, the diet and the changing lifestyle and exercise. So we have difficulty with the patient before. Even if we sit with them and we do the diet, they don't follow. They just, have the surgery in their mind and they don't want to do anything else. So basically, it's after the surgery here in Kuwait, but we have some cases that we follow before and after. So it depends all on the patient.
So basically, they come predetermined that they just want the sleeve.
Yes.
After
They believe that
doing-
it's the only solution for them. They say they tried everything. So
But they usually don't try.
I don't think
From
they
your
did try.
experience, do they actually try?
maybe they tried, but those fad diets that over the net, or my friend did this, so I'm going to do the same thing. The diet has to be customized to the patient. Everybody is different. So that's the problem, I think, because if you're going to do, for example, the high protein diet, which is very famous now, high protein, low carb diet, over the long term, you're going to be, bored with it. You want something different. It's not practical to eat just protein sources. So that's what they're doing. They're not following with a dietitian. They don't follow the exact rules of changing the habits, instead of just having like a schedule, eat this and don't eat that. So I think that's why we have a problem with them, is they don't start correct. That's why they fail on the long term. So they go for the surgery.
But some of patients, they don't know that they can actually approach a dietitian, or they don't even know that we actually have dietitians they can approach. How can they approach you? I mean, should they get a referral, or should they simply come to the hospital and ask for a dietitian?
Well, it's the doctor who refer the patient most of the time. But now the awareness is increasing. Recently, a lot of people are becoming, health conscious. They want to eat right, even if they don't need to lose weight. They just want to eat right. They want to know what's healthy for them and what's not good for them. So recently, everybody knows that there are dietitians. You can go either in private or in hospitals. But mostly, the protocol is that the doctor has to refer the patient for the dietitian after they check on their status and their lab reports.
So, Ms. Amna, after the patient has done their sleep, what should they expect to eat? What should they be eating?
Okay. We have 3 to 4 phases. The first phase is pure liquid. We start with clear fluids, week 1 post-surgery, and then week 2 we add a little bit of thick fluid with the clear fluid to see if the patient is okay, they have no problem, they can tolerate the thick fluid. Usually it's 2 weeks. Some patients we do more than 2 weeks, some patients less than 2 weeks. Then phase 2 is the smashed or the puree phase, where the patients start introducing food, but most of the food has to be soft and pureed, blended well. Phase 3 is after the puree. The puree is around 1 month. After that, they start the soft diet, eating everything, but they have to cut it small pieces. They have to chew thoroughly and just avoid fatty food, grilled instead of fried food. And then phase 4 is just eating normally, but we try to focus on changing their lifestyles, their eating habits. We focus on the problem that got them into the obesity status. For example, some people, they eat a lot of sweets, they eat a lot of chocolate. So we try to fix this problem. Other patients, they eat fast food. They eat a lot of, unhealthy food in a large amount. So we try to focus on the problem for each patient and change those eating habits so that they can continue even after they reach their goal weight. They can still keep it off for a long time.
So basically, trying to change the habits of the patients is the number one problem, or most problem that you have with the patients.
Yes.
What about the surgeons? Do you have a problem dealing with surgeons? Dr. Noor was saying arrogant, that we were a bit hard. So as dietitian, how is your communication, or how is your multidisciplinary approach with the surgeons?
Well, in general, we don't have a problem. The surgeons are very, cooperative. They know that this is the dietitian's role and this is their role. Once the surgery is finished, the surgeon's role mostly is the surgery itself and then the follow-ups for the ones. But it's us who follow the patient, their eating habits and their plan. Sometimes we have problem with surgeons. They give their own diet and then we come and say, no, don't do this. So there is a clash,
There's a conflict.
and the patient is like, I'm going to follow the doctor's order or the dietitian's. But it rarely happens. Usually most of the doctors are, cooperative, and they know that this is our job and this is their job.
What is the number one advice that you would give all your patients?
The number one advice is to try to exercise post-surgery and change your eating habit. It's not about eating a specific kind of food. You can eat everything, small portion, more frequent meals, eating healthy, just avoid certain types of food. So if you can change your lifestyle, can eat healthy food and still live normal, you can go eat out, you can do everything you want, but just learn how to pick right. Even if you go into even if you're going to eat in a restaurant, you have to pick the right food from the menu. Then just live normally. There is no bad food and good food. It's just how you pick the right food and the proportion, the amount of the food.
Do you have a problem with compliance as the surgeons do?
Yes, a lot of patients, they just believe that if I do the surgery, then I can eat everything I want and I'm still going to lose weight. And it's a struggle for us. We try to convince them that it's not a miracle. It's a tool. The surgery is a tool to help you achieve your goals, to give you the willpower to continue. If you're going to go under a surgery, if you're going to do all this, complication, deal with everything, then why not stick to the healthier lifestyle? So yes, we do have this problem with the patient, and a lot of them come after a year, they gained a little bit of weight, or maybe some patients, they gain all the weight that they lost and more after a year or two from the surgery.
And what is usually the main problem that would make them gain that weight back?
The idea that they can eat everything and still lose weight, especially the chocolates and the cakes, sweets. What they do is that they take healthy food out of their diet and then they add the chocolate. It is a game of calorie, like we said, but still you don't want to miss on the healthy nutrient, the protein, the carbs, the good fats. If you eat a piece of chocolate instead of chicken, then maybe it's the same calorie at the end, but the nutrients are a lot different. So I think the main problem is the desserts.
If you give them a cheesecake and then we give them the food that they're expected to eat, I mean, I'm sure that the difference in taste is going to make them ask for the cheesecake. So how can you play around with the taste, or how can we encourage them to drink the proteins or the supplements that you're trying to give?
I always recommend that they choose the food they like. I will not force a specific schedule for them. You have to eat chicken, you have to eat fish. Some patients, they're vegetarian, or maybe they do not like the protein source. So you just make a deal with the patient that you pick the food you like. We also recommend that they use some kind of sweetener. They can use flavors. Try to make the food with maybe lemon. Try to make the food interesting. If it's a diet food, it doesn't mean it has to be, tasteless. So it depends on the patient, but mainly we tell them what the food you like, what is the food that you like, and then we fixed the whole schedule for them based on their preference.
So, Anna, you were kind enough to get us some of your products that you're using.
Yes.
So what are those, and are these supposed to be for post-sleep patients?
They're mainly for everyone who cannot get enough protein from their food. For the sleep patients, the problem is always protein. This is just a supplement they can depend on to get enough protein. Our goal is to get 60 to 80 grams per day, and it's very difficult because the stomach is really small, and most of the food that is rich in protein is hard for them to digest. They just feel it's either heavy on their stomach, or they just don't like the taste of it. So we tell them, especially at the first 2 weeks, to use the protein. Most of the patients, they like this one because it's liquid.
Does it taste good? Do you mind if I taste it?
I love the taste of it, sure. It's it tastes like juice. Juice, diluted with water.
Wow, it tastes good.
It tastes good. You don't
It
feel
really
like
does taste good,
yeah.
actually.
The other one is the powder. The powder is more convenient because you can mix it with the soup. You can mix it. You can cook with it. But a lot of the patients, they just don't like the taste. I personally think it tastes good, but I think it's a psychological issue here because it's powder and you're mixing it, and they feel like it's a medicine. It's not a supplement for
We
them.
have a question actually from a viewer. I think he's a bodybuilder, and they're asking, can they use the proteins
Yes,
for their?
yes, it's
they're
exactly
using it
the
for
same.
lean body, their lean muscles.
Yes, it's
I think
exactly
we're gonna
the same
need
thing.
we're gonna need you back for another episode specifically for the bodybuilders. We'd love to
Inshallah.
have you back.
Yes, sure.
One last question, Ms. Amna. Supplements. Are you with or are you against? Or you are with getting those supplements naturally through food?
Food is always better. If you're gonna get your nutrient from food, it's better absorption, tastes better. But for the bariatric patient, it's really hard to get enough nutrient from the food. So I highly recommend supplement, except if the patient can actually eat more than 8 meals per day to get the needed amount. But yeah, I'm with the supplement.
And as a fellow surgeon, I'm gonna have to ask you that. Surgeries, are you with or against? I'm sorry, I had to ask.
Well, I'm with the surgeries, but not for everyone. Some patients, they cannot depend on the diet alone. So yeah, I'm with the surgery, but if you are gonna apply the rules, for example, we have some patients that are 80 kilos. Why would you do a surgery to lose just 20 kilos? So for certain rules, for certain patients, for the very heavy patient, I'm with the surgery. Like I said, it gives willpower. It gives them the push, to change their eating habit. So for some people, yeah, I'm with it.
Ms. Amna, I think that we are running out of time. Please do promise us that you will have to come back
I
for
do, I
another
promise.
episode. We definitely want to hear more of you. I didn't have enough. I have a lot more questions to ask you about. And ladies and gentlemen, thank you for watching us today at the Healthy Life show, and we hope that you would tune in with us next week, and we hope to